Have you ever had a urinary tract infection? Or maybe known someone who has?
Oh, chances are, yeah. They're incredibly common.
Right. But what happens when it's not just a typical UTI? When it becomes something, well, far more serious?
Exactly. We're talking about complicated UTIs or CUTIs.
And these are a whole different ballgame, aren't they?
Completely. Much tougher to treat. They can lead to serious complications.
And doctors are facing some really intense, high-stakes decisions about how to tackle them.
Absolutely.
So today's deep dive is into the cutting-edge 2025 guidelines from the Infectious Diseases Society of America, the IDSA, specifically on managing and treating these complicated urinary tract infections.
And these guidelines, they're not just thrown together.
No, definitely not. Our sources, they're meticulously compiled. You've got a broad panel of experts, different medical fields.
Emphasizing tons of research, clinical trials.
Yeah.
It's comprehensive.
Exactly. So our mission today, we want to equip you with the essential knowledge. We'll highlight the crucial decisions, maybe some surprising factors, that go into effective treatment.
Especially now, with rising antibiotic resistance being such a huge issue.
A huge issue. We'll show you how medical experts navigate these complex choices to, ensure the best patient outcomes.
Okay, so to really get into this, we first need to be clear on what makes a UTI complicated.
Right. It's not just any UTI.
No. Often it involves the patient's underlying health conditions, maybe diabetes or kidney problems. Or sometimes there's a structural issue in their urinary tract itself.
Like a kidney stone or something.
Exactly. Something that makes the infection much harder to clear, and the stakes are high.
Yeah.
CUTIs are actually a leading cause for emergency department visits and hospital admissions too.
Wow.
And the biggest challenge, frankly, it's the increasing number of bacteria resistant to common antibiotics.
So resistance problem again.
It means doctors are constantly looking for new solutions. Treatment selection is, it's really a moving target.
So how do clinicians even start to navigate this minefield of resistance and patient factors?
Well, that's where these IDSA guidelines come in. They offer a really practical 4-step roadmap.
Okay.
Think of it almost like a decision tree. It's designed to help them make those critical choices quickly, effectively. Get the right drug to the right patient at the right time.
A 4-step roadmap. Okay, let's walk through it. What's step 1?
Step 1 is first, and arguably the most critical, assessing just how sick the patient is.
How sick?
Meaning, specifically, are they in sepsis? Or even worse, septic shock.
Okay, define sepsis for us quickly. It's more than just a bad infection.
Much more. Sepsis isn't just the infection itself. It's your body's response spiraling out of control. It starts causing organ damage, organ dysfunction.
Serious stuff.
Very serious. Doctors use tools like the SOFA score to identify this. If certain organs are starting to struggle, it signals critical danger. We're talking a significant risk of death in the hospital, maybe over 10%.
And septic shock is even worse.
Even worse.
Yeah.
That's sepsis, where the blood pressure plummets, stays dangerously low even after giving fluids, and organs are clearly failing. That carries a massive mortality risk, over 40% in some studies.
Over 40%. Wow. So why is getting that severity assessment right at the start so incredibly critical?
Okay, here's the vital takeaway. For those sickest patients, the ones with sepsis or septic shock, that initial antibiotic choice.
Yeah.
It isn't just important. It can literally be a matter of life or death.
Life or death.
If you get that initial empiric antibiotic wrong, what we call inappropriate empiric antibiotic therapy, or I8,
okay.
the risk of dying could jump significantly. Studies suggest maybe a 50% higher odds, though we have to be careful.
Careful how?
Well, a lot of this evidence comes from observational studies. You can't ethically randomize sick patients to get a wrong antibiotic.
Right, of course.
So you can't say with 100% certainty the wrong drug caused the death. There could be other factors. But the clinical principle is really strong. For the most vulnerable, getting that first shot right away is paramount.
Okay, so getting it right up front is key for the really sick. But what about patients who don't have sepsis?
That's the contrast. For them, the ones with the lower mortality risk, say 5% or less, getting that initial antibiotic wrong, I8, is much more likely to lead to things like clinical failure.
Meaning
Maybe a delayed recovery, a longer hospital stay, needing different antibiotics later. It's obviously not good, but it's less likely to directly increase their risk of death compared to the septic group.
Got it. So this totally changes the approach depending on how sick they are.
Dramatically. For septic patients, the priority is aggressive, broad-spectrum coverage. You cast a wide net immediately.
To make sure you hit something that works.
Exactly, because mortality is the immediate, overwhelming concern. But for the non-septic patients, we pull back.
Okay.
The focus shifts more towards antibiotic stewardship.
Stewardship using antibiotics wisely.
Precisely. Using the narrowest effective antibiotic possible. This isn't just about that one patient. It's about preserving these precious drugs so they work for everyone else in the long run, slowing down resistance.
Right, makes sense. So step 1, assess severity. That dictates the initial aggressiveness. What's next? The patient's story doesn't just start when they hit the ER, right?
Exactly. Step 2 is looking at patient-specific risk factors for resistant organisms. Their history holds vital clues.
So, thinking like a detective, you said. What kind of clues are we looking for?
One of the most impactful clues comes from prior urine cultures, if they've had UTIs before.
Yeah.
The crucial finding, and a key suggestion in the guidelines, is to try and avoid antibiotics if that patient previously had a bug isolated from their urine that was resistant to that specific drug.
Okay. Seems logical.
It's more than logical. It's powerful. When the initial therapy choice for the current infection is concordant with that prior lab data.
Meaning it matches what worked or didn't work before.
Yes. The likelihood of picking an appropriate antibiotic this time increases by at least 7-fold.
7-fold. That's huge.
It's incredibly predictive. Now, it's not perfect. Interestingly, if a prior culture showed an antibiotic worked, it was susceptible, that's actually a better predictor that it will work now. The negative predictive value, or NPV, is generally above 80%.
So past success is a good sign for future success.
Usually, yes. But if a prior culture showed resistance, that's a bit less certain at predicting current resistance. The positive predictive value, the PPV, it varies more, maybe 40, 85%.
So prior resistance is a warning sign, but not a guarantee it's still resistant.
Correct. Factors like how long ago that culture was, if they had negative cultures in between, or took other antibiotics, all that can affect whether the bug is still resistant now. But it's still a very strong indicator to consider.
Okay, that makes sense. Go with the known winner if possible. Be cautious with past losers. Now, you mentioned risk factors. What about prior antibiotic exposure itself?
Ah, yes. That's another big one, especially fluoroquinolones.
Fluoroquinolones, or FQs. They come up a lot.
They do. And prior exposure to an FQ, say, within the past 12 months.
Okay.
That is a strong independent risk factor for having a fluoroquinolone-resistant organism this time. The pooled odds ratio is like 13.7.
13 times more likely to be resistant just because you took it in the last year.
Roughly, yes. And if the exposure was more recent, like in the last 3 months, the risk is even higher.
Wow. Which, as you mentioned before, raises that important question. Why are these FQs still even considered, given that risk and the known side effects?
It's a great question, and it really highlights a major dilemma. FQs, they were incredibly effective, and they have excellent oral bioavailability.
Meaning you could take them as pills and they worked well.
Exactly, which made them very convenient, especially for outpatient treatment. But their widespread overuse, frankly, has led to this dramatic increase in resistance.
We overused a good thing.
Pretty much.
Right.
And alongside that, we now have a much clearer picture of their serious side effects.
You mentioned things like tendon issues.
Tendinitis, even tendon rupture, aortic rupture or dissection, nerve damage, neuropathy, central nervous system effects like confusion or dizziness, serious blood sugar problems, even C. diff colitis. The list is concerning.
That sounds pretty bad.
It is. The FDA has even put out warnings, advising doctors to restrict their use for uncomplicated UTIs if other options exist.
So the official advice is caution.
Definitely. From a stewardship perspective, given the rising resistance and these serious toxicities, FQs should really be reserved.
Reserved for?
For cases where resistance isn't expected based on history or local patterns, or maybe where other effective options are truly limited, perhaps due to allergies or other drug interactions, there's certainly not the easy go-to choice they might have been years ago.
Okay, that clarifies the FQ situation. So we've assessed severity, looked at past cultures and antibiotic use. What's step 3 in the framework?
Step 3 covers other patient-specific considerations. It's really about the practicalities of care for this individual.
Beyond the infection itself.
Exactly. Good clinical practice always dictates that clinicians must account for known antibiotic allergies. That's crucial.
Obvious, but critical.
Critical. Also, any other health conditions the patient has that might make a particular drug dangerous contraindications. And of course, potential drug-drug interactions with other medications they're taking.
Right, need to make sure the treatment doesn't cause a new problem.
Precisely. And it's also just common sense, really. You generally avoid an antibiotic the patient was already taking when their CUTI symptoms started or when they just finished a course of. It likely wasn't working or wasn't enough.
So check allergies, check contraindications, check interactions, check recent use. Basic but essential safety checks.
Absolutely essential for safe and effective care.
Okay. Severity, risk factors, practicalities. What's the fourth and final step in this initial decision process?
The fourth step involves looking at local intelligence, primarily for the sickest patients. This is where the antibiogram comes in.
The antibiogram. You mentioned this is like a local report card for antibiotics?
That's a good way to put it. It's a report, usually updated annually, that summarizes how susceptible local bacterial isolates the bugs found in patients at that hospital or clinic are to various antibiotics.
So it tells you what's generally working well in your specific area.
Yes, it gives you a snapshot of local resistance patterns. But the guidelines are quite specific about when to use it.
It's not for everyone.
No. The suggestion is to consult an antibiogram only for patients who have CUTI-related sepsis.
Only for the septic patients.
Right. And even then, only if the antibiogram is truly local from the same facility recent, meaning within the past 12 months, and relevant, meaning it reflects data from a similar patient population, like ICU versus general wards, if possible.
Okay, specific conditions for its use. And there were thresholds mentioned.
Yes. For patients in septic shock, the most critical group, the goal is to pick an empiric antibiotic, where the antibiogram shows susceptibility is 90% or higher for the likely bug.
Aim high for the sickest.
Exactly. For sepsis without shock, the target threshold is a bit lower, maybe 80% or higher susceptibility.
Why these specific numbers?
The idea is to minimize the risk of that inappropriate initial therapy, the IE8. Even a small increase in mortality risk from IE8 is something you desperately want to avoid in septic patients.
So the antibiogram helps fine-tune the choice for septic patients based on local data. Why not use it routinely for non-septic patients then?
Good question. For patients without sepsis, remember, the impact of that initial antibiotic choice on mortality seems minimal.
Right. It affects recovery time more than survival.
Correct. So routinely using the antibiogram to guide towards broader spectrum agents in non-septic patients could actually do more harm than good from a stewardship perspective. It might drive up resistance without providing a substantial survival benefit for that lower risk group.
Balancing individual risk versus the population risk of resistance.
Precisely. Plus, there are challenges. The antibiogram's value for predicting resistance in an individual patient is still debated and unproven in large trials.
It's population data, not necessarily my data.
Exactly. And which bug do you even look up on the antibiogram if you don't have a prior culture? Usually you default to E. coli, the most common cause, but is that right for this patient? Hospital-wide data might not reflect the specific unit the patient is in.
So it's a useful tool, but requires careful interpretation and isn't a magic bullet.
Definitely not a magic bullet. It raises that important question. How do clinicians effectively balance this general population data with the unique history and needs of the individual sitting in front of them?
A constant balancing act. Okay, this framework severity, risk factors, practicalities, antibiogram for sepsis makes sense for choosing the initial therapy. Now let's dig into the specific drugs themselves. You touched on some, but let's look closer at the main classes, keeping that balance of efficacy, side effects, and stewardship in mind.
Okay, let's group them a bit. First, you have the, let's call them long-standing workhorses. Things like third and fourth generation cephalosporins. Ceftriaxone is a common example.
Ceftriaxone, right. Hear that one a lot.
Yes, long history of use, still a very frequent choice for empiric therapy, especially for patients without sepsis.
Why them?
Well, they cover many common UTI bugs. They can often be given just once a day, sometimes even as an injection if needed, and they're generally low cost.
So effective, convenient, affordable for many cases. What's the downside?
The main threat now is the increasing prevalence of those ESBL-producing organisms we mentioned.
The superbugs that break down these antibiotics.
Exactly. If a patient has a history of ESBLs, or if local resistance rates on the antibiogram are high, say over 10% resistance for septic shock or 20% for sepsis without shock, then these might not be reliable enough as the first choice. You need to be cautious.
Okay, so cephalosporins, good baseline, but watch out for resistance. What's next?
Then you have broader spectrum agents like piperacillin tazobactam, often called pip-tazo.
Pip-tazo, heard that too.
It's got wider activity, importantly including coverage against Pseudomonas aeruginosa, which can be a tricky bug. Studies suggest it likely leads to similar clinical cure rates compared to even some of the newer agents.
Sounds good. Challenges.
The dosing often requires a more thoughtful approach. To be most effective, especially against tougher bugs, it often needs to be given as a prolonged or even continuous infusion over several hours.
Which can be harder for nursing staff or pharmacy to manage?
It can create logistical challenges, yes. Plus, it can have side effects like low potassium or causing fluid overload in some patients. And like everything else, we're seeing rising resistance, especially among ESBL producers and multi-drug-resistant Pseudomonas. It's often preferred for non-septic CETI, where you need broader coverage than ceftriaxone, but maybe don't need the absolute biggest guns yet.
Okay, Piptazo, broader, hits Pseudomonas, but dosing and resistance are concerns. What are the biggest guns?
That would be the carbapenems, drugs like meropenem or imipenem.
Carbapenems, these are serious antibiotics.
Absolutely. They have the broadest spectrum of activity among the commonly used agents. They are incredibly valuable, even crucial for critically ill patients.
Especially those septic shock patients we talked about.
Exactly. For empiric treatment in patients with sepsis, especially septic shock, carbapenems are highly valued. The goal is to avoid that inappropriate initial therapy and reduce mortality risk. They give you the best chance of covering whatever resistant bug might be there right from the start.
So essential for the sickest. What's the stewardship angle here?
Because they are so broad and so vital for resistant infections, they are absolutely not a first-line empiric choice for patients without sepsis.
Hold them back unless absolutely necessary.
Precisely. Using them unnecessarily just breeds more resistance to our last lines of defense. And remember, for non-septic patients, the potential harm from slightly delayed appropriate therapy is much lower than the risk of mortality. So, stewardship dictates we reserve carbapenems.
Got it. Carbapenems. Top tier, crucial for sepsis shock, reserved for stewardship otherwise. What about the even newer drugs designed for resistance?
Right, those are the novel beta-lactam beta-lactamase inhibitors, or BL-BLIs. Think ceftazidime avibactam or ceftolozane tocembabactam.
Catchy names.
Yes. These were specifically designed to combat multi-drug-resistant gram-negative bacteria, including those nasty CREs, carbapenem-resistant Enterobacteriaceae, which are resistant to carbapenems.
So they work when even carbapenems might fail.
That's the idea. Clinical trials show they generally achieve similar clinical cure rates, patients feeling better compared to other drugs like carbapenems or Piptazo.
Yeah.
But interestingly, they often achieve higher microbiologic cure rates.
Meaning they're better at actually eradicating the bacteria from the urine.
Exactly. Whether that always translates to better long-term patient outcomes is still debated, but they're very effective at killing these resistant bugs.
Sounds amazing. What's the catch? There's always a catch.
Cost. The catch is definitely the cost. These drugs are incredibly expensive.
How expensive?
A single dose can easily be over $1,400. Compare that to maybe $30, $150 for a dose of older agents like ceftriaxone or Piptazo.
You're $1,400 a dose. Wow.
Yeah. So stewardship is paramount here, too, driven heavily by cost and the need to preserve these agents. They should be reserved for documented multi-drug-resistant pathogens, or perhaps used empirically only in a patient with septic shock who has very strong risk factors for harboring such a resistant organism.
Yeah.
They're absolutely not first-choice empiric therapy otherwise.
Okay, novel BLBLIs. Powerful against resistant bugs, high microbiologic cure, but very expensive and reserved. Any others in that super specialized category?
There's also cefiderocol. It has a really unique Trojan horse mechanism.
Trojan horse?
Yeah, it basically tricks highly resistant gram-negative bacteria into taking it up by using their iron transport systems, and then it kills them from the inside.
Clever.
Very clever mechanism. Again, trials show similar clinical cure rates to comparators, but often higher microbiologic cure rates against very resistant bugs. Well, we are already seeing some emerging resistance, which is worrying, and dosing needs careful adjustment for kidney function. Like the novel BLBLIs, it's generally not preferred for empiric use due to stewardship and cost. It's ideally reserved for highly resistant infections where, the bug's resistance mechanisms make cefiderocol a good targeted choice.
Right. Specialized tools for specialized problems. What about some of the older drug classes? Aminoglycosides.
The older aminoglycosides, gentamicin, amikacin, tobramycin, they've been around a long time.
And have a reputation for side effects.
They do. Known risks like nephrotoxicity, kidney damage, and ototoxicity, hearing, or balance problems. While some older retrospective studies hinted at a potential mortality benefit in certain situations, that evidence is considered very uncertain.
Why uncertain?
Likely due to bias. Healthier patients might have been more likely to receive them, making it look like the drug improved outcomes when maybe the patients were just less sick to begin with.
Confounding factors.
Exactly. So given the toxicity concerns and the limited, high-quality modern evidence supporting their routine use over safer agents, they're generally not preferred today, especially for empiric therapy. If used, they require really close monitoring, including drug-level assessments.
Okay, older aminoglycosides. Toxicity concerns, uncertain benefit, generally avoided now. Any newer ones?
There is plasmamycin, which is sometimes called a next-generation aminoglycoside. It was designed to overcome some resistance mechanisms that affect the older drugs.
So potentially more effective against resistant bugs?
Potentially, yes. But the trials still raise some concerns about nephrotoxicity and ototoxicity, similar signals to the older agents. So again, due to these potential serious adverse events, it's also generally not a preferred agent.
Got it. Newer aminoglycoside, same toxicity worries. Lastly, what about oral options for empiric therapy in CUTI? Can you start with pills?
Sometimes, yes, especially for patients who aren't sick enough to be hospitalized. Oral empiric antibiotics like fluoroquinolones or TMP-SMX, trimethoprim sulfamethoxazole, Bactrim.
Bactrim, right.
Or sometimes oral cephalosporins are used. But there's significant caution needed.
Because of resistance.
High resistance rates, especially for FQs and TMP-SMX in many areas. And the evidence supporting the effectiveness of oral cephalosporins for true CUTI, which can involve kidney tissue, is less robust than for IV options.
Okay. And are there any oral drugs often used for simple UTIs that are definitely not okay for complicated ones?
Yes, that's a key exclusion. Nitrofurantoin, macrobid, and oral phosphomycin.
Why not those? They work well for bladder infections.
They do, but they don't achieve adequate drug concentrations in the kidney tissue itself or in the bloodstream.
Ah, so they stay mostly in the bladder.
Pretty much. Which is fine for a simple cystitis, a bladder infection. But for a complicated UTI, which might involve the kidneys, pyelonephritis, or the bloodstream, these drugs just won't reach the site of infection effectively.
Right.
So they're generally not appropriate for treating CUTI.
Okay, that's a really important distinction. So once these initial empiric choices are made, based on severity, risks, and maybe the antibiogram, the lab results eventually come back, right? The urine culture.
Exactly. Usually within 24, 48 hours, you get identification of the bacteria and, crucially, its susceptibility pattern, which antibiotics actually kill this specific bug.
And then the game changes. Here's where it gets really interesting, you said. It's about precision.
That's right. This leads to the principle of de-escalation.
De-escalation, meaning?
Meaning there's a strong suggestion in the guidelines. As soon as those urine culture and susceptibility results are available, clinicians should switch from the broad-spectrum empiric drug they started.
The one they chose based on the best guess.
Yes. Switch from that to a targeted, narrower spectrum antibiotic that is known to be effective against the specific bug causing the infection.
Narrowing the focus once you know the target.
Precisely. Why does this matter? Several reasons. First, it's a cornerstone of antibiotic stewardship, using the narrowest effective drug. Second, some evidence suggests targeted therapy might actually improve clinical cure rates compared to staying on broad coverage unnecessarily. And third, it may reduce the risk of the infection recurring later.
Makes perfect sense. Hit it hard initially if needed, then refine the attack once you have better intel. Are there challenges to de-escalation?
The main challenge can be practical, especially in the outpatient setting.
How so?
Well, imagine a patient who was seen in the ER, started on a broad IV antibiotic, maybe felt better quickly, and was discharged home with a prescription for a broad oral antibiotic before the final culture results were even known.
Right, they're already home taking the meds.
Exactly. It can be logistically difficult and sometimes maybe not even necessary to then call them back or change their prescription mid-course, especially if they're improving well. So while it's a strong principle, implementation isn't always straightforward outside the hospital.
Okay, de-escalation. The gold standard, once cultures are back, prioritizes stewardship, aims for better cure, but can have practical hurdles. So, stepping back from the specific steps and drugs. What does this all mean for us, the learners? How does this connect to the bigger picture?
I think the guiding principle that weaves through all of this, and really all of modern infectious disease practice, is antibiotic stewardship.
Stewardship again. It's clearly central.
It has to be. It's not just, a buzzword or a nice to have. It's fundamental. It means always striving to use the narrowest effective antibiotic for the shortest effective duration.
Why is that so critical?
It minimizes side effects for the patient, It helps protect their microbiome, the trillions of good bacteria living in and on us. It reduces the risk of secondary infections like nasty C. diff colitis, which thrives when antibiotics wipe out normal gut flora. And most critically,
Yeah.
it slows the emergence of further antibiotic resistance.
Which threatens everyone.
Exactly. The unfortunate, inescapable truth is that overuse and misuse of antibiotics inevitably selects for resistant bacteria. Every time we use an antibiotic, especially a broad one, we risk making future infections harder to treat. It's like we're constantly draining our medical arsenal against infections.
A really sobering thought. And beyond stewardship, what about the patient's perspective and the system costs?
Right. While preventing death is obviously paramount for those septic patients, for many others with CUTI, where the mortality risk is low, what matters most to them is clinical cure.
Just feeling better, getting back to normal life.
Exactly. That's often their primary goal. But we also can't ignore the huge cost implications.
We touched on the price difference between drugs.
Yeah, the difference is vast. You might have older generics costing pennies or a few dollars per dose versus these cutting-edge novel agents at over $1,400 a dose. That has massive implications for hospital budgets, insurance coverage, patient access, and overall healthcare equity.
And just getting an IV adds costs too, right, compared to pills.
Absolutely. 4B administration itself involves nursing time, pharmacy preparations, IV lines, pumps. It adds significant cost and complexity compared to just taking an oral medication. These are all factors that have to be weighed.
A complex web of clinical, stewardship, patient, and economic factors. This leads perfectly into thinking about what we don't know yet. What are the big, unanswered questions or areas for future research highlighted by these guidelines?
Oh, there are definitely exciting areas still needing work. For instance, really clarifying the clinical relevance of that microbiologic cure versus patient symptoms.
Does it matter if the bug is technically gone if the patient still feels sick or vice versa?
Exactly. What does it truly mean for the patient long-term if bacteria are still present in the urine, but they have no symptoms? The classic asymptomatic bacteriuria dilemma, but in the context of a recent CUTI. We need more data there.
Okay, what else?
There's also a need for better ways to define and study UTIs, specifically in men. Often it's hard to distinguish clearly between, say, an infection just to the prostate, prostatitis, versus one that is ascended to the kidneys, pyelonephritis. Better definitions would help tailor treatment.
Makes sense.
And crucially, something often overlooked. There's an urgent need for more research into UTI epidemiology, risk factors, and even treatment outcomes, specifically in transgender and gender-diverse individuals.
An area lacking data.
Severely lacking. Clinical data in these populations is currently insufficient, and we need dedicated research to ensure equitable and effective care.
That's incredibly important. Anything else on the research horizon?
Well, the guidelines also point to the continued need for more real-world data on the actual impact of using antibiograms to guide empiric therapy. Does it truly improve outcomes? And similarly, how can we best integrate rapid molecular diagnostic tests that might identify bacteria and resistance genes much faster than culture, into clinical practice to guide initial therapy effectively? Lots still to learn.
Definitely sounds like the field is still evolving rapidly. Okay, that brings us towards the end of our deep dive today. Let's try to recap the core takeaway.
I think the main message is that the 2025 IDSA guidelines offer this dynamic four-step approach for initial CUTI management. It really forces clinicians to prioritize based on patient severity first.
Sepsis or no sepsis being the critical branch point.
Exactly. Then layering in individual risk factors like prior cultures and antibiotic use, considering practicalities like allergies, and finally, using targeted local data, the antibiogram, but really only for those higher-risk septic patients.
And this whole framework is designed to be adaptive, right? To deal with that ever-changing landscape of bacterial resistance.
Precisely. It aims to help clinicians make the best choices possible, balancing immediate patient needs with the long-term imperative of stewardship.
Which leads us to that final provocative thought.
Yeah, I think this whole discussion raises a really important, almost philosophical question for medicine today. In a world where antibiotic resistance is this constant growing threat, how much should the immediate potential benefit for an individual patient weigh against that long-term societal imperative of preserving our most powerful, often last resort antibiotics for the future?
Wow. That's a heavy question. There's no easy answer there, is there?
No easy answer at all. It's a delicate, ethical tightrope walk that clinicians navigate every single day.
A true ethical and public health challenge. Well, that is certainly something for all of us to think about. We really encourage you to consider that balance. Thank you for joining us for this deep dive. We hope we've helped unpack this complex topic into clearer, actionable knowledge. Join us again next time as we continue to explore important developments in medicine.